Hello, I am Doctor, and welcome back to Integrated Health, where our focus is always on providing clear, practical knowledge to support health, comfort, and dignity in advanced age. Today, we are diving deep into a subject that is often whispered about, but rarely discussed openly and honestly: the signs of decline in the elderly. Specifically, we are going to tackle the incredibly popular and often deeply misleading internet topic: the 7 signs that appear in the bodies of elderly people 1 year before death. If you are a caregiver, a spouse, or an adult child watching this, you've probably searched this exact phrase. You may have seen the lists promising predictive power: sudden weight loss, a decrease in social engagement, increased sleeping hours. It is human nature to look for a crystal ball, isn't it? When facing the great unknown of our final years, we crave certainty. We want a clear map, a deadline, so we can prepare, emotionally, practically, and spiritually. We want the grace of knowing exactly when to shift our focus from aggressive maintenance to focused comfort. But this search for certainty, while understandable, often leads us into a trap of anxiety, self-blame, and medical myths that simply do not hold up to clinical reality. Let me share a deeply personal and clinical observation with you. I remember a woman named Eleanor. She was 88, living comfortably at home, mostly independent, but with moderate dementia and increasing frailty. Her daughter, Sarah, was meticulous. Sarah was not just a caregiver, she was an investigator. She followed every list she read online. One day, Sarah brought Eleanor into my clinic, visibly shaking. She had charts, colored graphs detailing Eleanor's life over the last 9 months. She pointed specifically to 2 data points that had sent her into a spiral. First, Eleanor had started sleeping 2 hours more per day, an undeniable increase in rest. Second, Eleanor had begun refusing her favorite dessert, a clear dip in appetite. Sarah looked at me, eyes filled with tears, and said, "Doctor, the lists say these are the signs. The article said if 3 of the 7 markers appear, the prognosis is fixed. I'm exactly 9 months away from the predicted 1-year mark. What did I miss? Why didn't I realize the increased snapping wasn't just old age, that it was the countdown?" Sarah wasn't looking for a definitive answer about time. She was looking for absolution from the immense guilt that she had failed to read the universal medical script. And here is the direct clinical truth I needed Sarah and all of you to hear. The human body, particularly in advanced age, does not follow a precise, preset calendar dictated by an arbitrary list of 7 symptoms. The idea that we can medically predict the end of life 1 year out based on a checklist is a comforting fantasy, but it is a destructive myth. It causes caregivers to spend precious time worrying about a theoretical deadline, instead of focusing on the present quality of life. When we talk about the end of life, we are not talking about a sudden flip of a switch. We are talking about a cascade, a gradual decline of the body's major organ systems, a systemic slowing down that can take months, or in some cases, many years. The changes that occur are often subtle, confusing, and they overlap perfectly with symptoms that are entirely treatable. Is that fatigue a sign of decline, or is it a sign of untreated anemia? Is the weight loss the onset of the final cascade, or is it a dental problem making chewing painful? These viral lists, the ones that promise 7 simple answers, prey on our deepest fear, the fear of the unknown. They offer simplicity where only complexity exists. They tell you to watch for increased confusion or loss of interest, but fail to explain that these symptoms could equally signal dehydration, an untreated urinary tract infection, or poor sleep hygiene. If we jump immediately to "this means death in 12 months, we miss the critical window to intervene and potentially reverse or stabilize a condition. So let's establish a clear boundary right now. We are going to respect the sensitivity of this topic, but we must reject the fear-mongering of pseudoscience. As your geriatrician, I promise you clarity. We are not going to look for mystical markers of a specific date. Instead, we are going to look for real, clinically significant patterns of decline, the signs that indicate the body is requiring more support, more comfort, and a shift in treatment goals. We will look at those 7 frequently cited signs, but we will dissect them through the lens of true geriatric medicine, separating the treatable symptoms from the irreversible progression of advanced illness. Understanding the difference is not just about gaining knowledge, it's about reclaiming the peace of mind that allows you to be fully present with your loved one. This video is about preparation, not prediction. It's about knowledge that empowers you to ask the right questions of your healthcare team. Stick with me. We are going to demystify these symptoms so you can focus on what truly matters: dignity, comfort, and comprehensive care. Let's start by looking at the very first sign often cited: the change in eating habits. Become a Jay that empowers you to ask the right questions of your healthcare team. Stick with me. We are going to demystify these symptoms so you can focus on what truly matters: dignity, comfort, and comprehensive care. Let's start by looking at the very first sign often cited: the change in eating habits, specifically the profound loss of appetite. This is perhaps the most visible and concerning sign for caregivers, and it is crucial to understand its physiological root. When we age, our internal mechanics shift profoundly. It's not just about losing interest in food. It's a medically recognized phenomenon known as the anorexia of aging, which is then drastically accelerated by terminal or chronic illness. What exactly is happening inside the body? First, the sensory experience of food changes. Our sense of smell and taste, which drive appetite and pleasure, diminish significantly. Food simply becomes less appealing. Second, the delicate dance of appetite hormones is disrupted. The hormone ghrelin, which signals hunger and prompts us to eat, often decreases in production. Simultaneously, leptin, the hormone that tells us we are full, often increases or becomes hypersensitive. This means the senior feels full faster and stays full longer, consuming far fewer calories naturally. Third, and perhaps most significant in the final years, is the change in the basal metabolic rate. As we naturally lose muscle mass, a process called sarcopenia, our energy expenditure drops. Muscle is metabolically active tissue. Fat is less so. If an 85-year-old required 2,000 calories a day when healthy, that caloric requirement might naturally drop to 1,500 or even less, simply because there's less tissue to maintain. When this natural downshift is combined with an underlying illness, the body enters a conservation mode, and the need for fuel drops drastically. Force feeding or aggressive supplementation at this stage often creates discomfort without providing a significant long-term benefit. This leads us directly into the second and third signs: weight loss and pronounced fatigue or lack of energy. These symptoms are two sides of the same physiological coin, often rooted in the concept of frailty. We need to clearly distinguish between normal aging and frailty syndrome. Normal aging means your reserve capacity is lower than when you were 30, but your body can still handle typical daily stresses. Your walking speed might slow down, but you can still recover quickly from a common cold. Frailty, however, is a state where the body's overall physiological reserve is severely depleted. Think of the body like a complex machine. In frailty, every system, the heart, the kidneys, the muscles, is functioning so close to its minimum capacity that even a minor stressor, a mild cold, a slight dehydration, a change in medication, can trigger a catastrophic cascading collapse, what we call failure to thrive. The noticeable signs, unexplained weight loss, muscle wasting, and profound unshakable fatigue, are indicators that the body's overall capacity to fight or recover is severely diminished. When you see these three signs together, they are not necessarily a direct clock ticking down 365 days, but they are a stark reflection of the body running out of its energetic reserves. This decline explains why the person requires more sleep and why functional decline, the inability to perform basic tasks like bathing or dressing, accelerates so rapidly in the final year of life. Now, let's address this acceleration in functional loss by introducing a critical concept for every caregiver and senior: the difference between independence and autonomy. Independence is the physical ability to do things, to drive, to cook, to dress yourself without help. It is entirely based on physical capability and functional status. As the body enters this period of advanced frailty, a loss of independence is inevitable and progressive. Autonomy, on the other hand, is the fundamental right and ability to choose and to decide what happens to you, even if you need physical assistance to carry out that choice. A person may lose the independence to get out of bed alone, but they must retain the autonomy to decide when they want to get out of bed, what they want to wear, and how they want their care structured. When we witness the acceleration of physical decline, the need for increased assistance, the increased frequency of falls, we are witnessing a loss of physical independence. But our absolute focus as caregivers and medical professionals must shift to protecting that person's autonomy. Their dignity, their voice, and their preferences must remain the central point of care. Understanding the physiology of decline helps us provide the appropriate physical support without ever diminishing the person's right to self-determination. Let's turn to the cognitive and social shifts that often accompany this stage: increased confusion, apathy, and social withdrawal. These signs are often mistaken for simple mental exhaustion, but they are deeply rooted in the body's energy crisis. Mild cerebral atrophy is a normal part of aging. However, in the context of advanced frailty, the cognitive slowing is compounded by constant physical exhaustion and systemic inflammation. The brain, though only a small percentage of body weight, requires an immense amount of energy, roughly 20% of your total resting metabolism. When the body is struggling simply to maintain heart function, kidney filtration, and respiration, higher-level cognitive processes, concentration, complex decision-making, planning, and social engagement become a massive, unsustainable energy drain. What may look like apathy or giving up is often the body ruthlessly prioritizing energy resources. The brain chooses survival over complex thought. Confusion and increased periods of deep sleep are often the brain's way of protecting itself from overload. This is why we sometimes see increased periods of what looks like depression or profound social withdrawal. They are physically too fatigued to engage with the world, and their minds are too taxed to process complex conversations. It is vital to distinguish between a gradual slowing of thought processes, which is part of frailty, and acute delirium, which is a rapid, severe change in mental status. If the change is sudden, say overnight, that is a medical emergency that demands immediate attention, as it may signal an underlying infection, drug toxicity, or severe dehydration. If the changes are slowly progressive over months or a year, that is part of the systemic shutdown, a physiological mandate for rest and reduced input. The final two signs, changes in skin integrity and increased frequency of infections, are also direct consequences of this depleted reserve and muscle loss. As weight decreases, the protective padding of fat and muscle is lost. This makes the senior incredibly vulnerable to pressure injuries, even with meticulous repositioning. The skin becomes thin, fragile, and less resilient. Furthermore, the immune system, like every other system, requires energy and protein to function effectively. Severe malnutrition and sarcopenia rob the body of the necessary building blocks to mount an effective defense against bacteria and viruses. What would be a mild cold for a younger person becomes a life-threatening pneumonia for someone in this state of advanced frailty. Increased or recurring infections, particularly of the urinary tract or respiratory system, are powerful indicators that the body's ability to defend itself has reached a critical low. So, when we look at these 7 interconnected signs, changes in eating, functional decline, fatigue, weight loss, apathy, skin fragility, and infections, we are not looking at arbitrary milestones. We are observing the physiological reality of the body's finite reserve capacity being extinguished. The time frame of 1 year is an average, not a guarantee, but these signs demand a critical shift in focus, from curative intervention to palliative comfort and holistic support. We have identified 7 physiological markers that often signal a critical, definitive shift in the body's reserves, a shift demanding an immediate change in approach. If you, or a loved one, are showing several of these patterns, the time for aggressive, curative intervention is likely over, and the time for aggressive, high-quality comfort care has begun. This is not a moment of defeat. This is the moment for precision, respect, and profound practical action. Here is the detailed protocol for how we pivot our focus to ensure the highest quality of life during this critical period. The foundational principle must be shifting from extending life to enhancing comfort. The great care. Pivot. Goals and medications. The very first action is an honest, direct conversation with the patient and the care team, your primary care physician, a geriatric specialist, and ideally, a palliative care consultant. 1. Define new goals of care, the DE aggressive mandate. If the goal is comfort, we stop interventions that cause discomfort without extending meaningful life. This means asking hard questions. Do we continue high-risk surgeries? Do we restart the heart if it stops? Do we push for intensive nutritional support through feeding tubes when the body is naturally rejecting food? In almost every scenario where these 7 signs are present, the answer is no. We transition formal documents like a DNR, do not resuscitate, and ensure the patient's wishes for comfort are explicitly documented and respected by all medical personnel, especially in emergency situations. 2. The critical role of deprescribing. One of the most dangerous protocols for a frail elderly person is continuing medications that were prescribed years ago for conditions that are now less relevant than their current comfort. This process is called deprescribing. Look critically at every pill the individual takes. Are they still necessary? For example, statins, cholesterol medication, or strong blood pressure medications designed to prevent a heart attack 10 years from now are often unnecessary when the body's timeline is significantly shorter. These medications can cause dizziness, fatigue, and lower quality of life today. Are they interacting negatively? Polypharmacy, taking many different drugs, increases confusion, fall risk, and stomach distress. Consult your physician to systematically reduce or eliminate non-essential prophylactic medications. Focus only on medications that relieve immediate symptoms, pain, or distress. 3. Pain management, the silent priority. Remember the sign of increased withdrawal and subtle agitation? This is often untreated pain, even if the individual denies it verbally. Many older adults minimize pain because they fear becoming a burden, or they believe pain is a natural part of aging. We must proactively manage pain. A pain scale should be assessed multiple times daily. If mobility is declining, pain from stiff joints or muscular aches increases dramatically. We utilize around-the-clock time-release pain relief, not just as needed. This consistency is vital to prevent the troughs of suffering that lead to withdrawal and anxiety. 4. Activating palliative and hospice services. Do not wait until the final week. Palliative care is specialized medical care focused on relief from the symptoms and stress of a serious illness. It can be started immediately, alongside curative treatments if necessary, but it is tailor-made for this transition period. Hospice care is specifically for those who choose comfort care and have a prognosis, generally of 6 months or less, if the disease runs its natural course. Initiating hospice early provides a full team, nurses, social workers, spiritual counselors, and aides, who provide comprehensive support to both the patient and the caregiver at home. This support network is crucial for managing the sign of increasing caregiver burden and fatigue. Protocol for daily practical care. When the body enters this phase, our practical care must adapt to its declining capacity, especially addressing the loss of mobility and weight appetite decline. 1. Nutritional adaptation. Comfort over calorie count. The decline in appetite is a natural physiological preparation for the end-of-life process. The body simply doesn't need or want the metabolic load of heavy food. Forcing calories will only cause distress, nausea, and reflux. Focus on desire. What does the person want? Ice cream, pudding, a sip of their favorite soft drink, a small amount of soup broth. Offer small, frequent meals of their favorite comfort foods, regardless of their nutritional density. The goal is pleasure and hydration, not meeting macro targets. Hydration. Hydration is still important for comfort, especially mouth moisture. Use small sips of water, ice chips, or specialized mouth swabs. If they are refusing fluids, aggressive IV hydration should be questioned, as it can sometimes increase fluid retention and discomfort. Edema. Assisted feeding. If they are feeding themselves slowly, ensure they are in the proper upright position to prevent aspiration, choking and/or food entering the lungs. If they are refusing to chew, transition to soft, pureed textures. 2. Mobility and movement, preventing catastrophe. The decline in mobility is a leading cause of the falls that often accelerate decline. Our goal is to maintain functional mobility, not fitness. Fall prevention is paramount. Immediately utilize assistive devices, walkers, canes, and especially grab bars in bathrooms. Ensure lighting is excellent and paths are clear of rugs, clutter, and electrical cords. If the patient exhibits the sign of increased sleepiness or lethargy, they are at an exponential risk of falling. Active and passive range of motion, ROM. Even if the patient is mostly chair or bedbound, the caregiver must gently guide their limbs through simple movements, lifting arms, bending knees, multiple times a day. This prevents joint stiffness, reduces the risk of painful muscle cramps, and helps prevent dangerous bed sores. Skin care. Pressure ulcers, bed sores, develop quickly when mobility decreases. Turn and reposition the patient every 2 hours if they are in bed, or every hour if they are in a chair. Use specialized pressure-relieving mattresses or cushions. Check the bony areas, hips, tailbone, elbows, and heels, daily for redness or warmth. 3. Home environment adaptation. The sanctuary. The physical space must become a sanctuary that supports the patient's increasing withdrawal. Simplicity and security. Simplify the environment. Keep essential items within easy reach, remote, phone, water. Remove anything that causes anxiety or visual clutter. Sensory management. Since hearing is often the last sense to go, maintain a calm, steady auditory environment. Quiet conversation, familiar music, or the presence of a ticking clock can be deeply comforting. Ensure natural light during the day, but keep the room dimly lit at night to prevent confusion and sundowning, worsening confusion in the evening. Commodes and bathroom access. Do not wait until it is too late to introduce a bedside commode. The difficult journey to the main bathroom dramatically increases the risk of falls and exhaustion. Prioritize easy access and minimize required movement. Addressing emotional and social well-being. The emotional and psychological signs, withdrawal, increased anxiety, and social disconnection, require specific non-medical interventions. 1. Therapeutic presence. Over conversation. The patient may stop initiating conversation or seem unresponsive. Do not mistake silence for absence. They are often acutely aware of your presence. Touch. Gentle, non-demanding touch is often the most powerful form of communication. Hold their hand, offer a gentle foot massage, or simply place a hand on their shoulder. Reminiscence and legacy. Even if the person doesn't speak much, talking to them about their life, old photos, shared memories, their accomplishments, validates their life experience and addresses the underlying existential anxieties that accompany this transition. Managing anxiety. Anxiety often manifests as restlessness or picking at sheets. Ensure pain is treated first, then create consistency. Routine provides security. If the patient is prone to delirium or confusion, reduce the number of visitors at one time, creating a quieter, more predictable environment. 2. Supporting the caregiver. The fatigue sign. Caregiver. Fatigue is one of the 7 critical signs because it directly impacts the quality of care provided. Scheduled respite. If the patient is receiving palliative or hospice care, utilize volunteer or aid services for scheduled, guaranteed time off. Caregivers must sleep, eat, and have dedicated time away from the patient's room to recharge. Burnout is a reality, not a moral failing. Community and support groups. Connect with local groups or social workers. Sharing the emotional burden of witnessing this decline is essential for mental health. We must understand that this final year, or whatever the remaining time frame may be, is a profound process. By implementing this protocol, by pivoting aggressively toward comfort, eliminating unnecessary medical interventions, managing pain proactively, and providing a safe, loving environment, we are not simply waiting for the end. We are actively shaping the final chapter of a cherished life with the dignity, respect, and comprehensive care they deserve. This focused, holistic approach transforms a difficult journey into a deeply meaningful passage. In providing a safe, loving environment, we are not simply waiting for the end. We are actively shaping the final chapter of a cherished life with the dignity, respect, and comprehensive care they deserve. This focused, holistic approach transforms a difficult journey into a deeply meaningful passage. We have spent our time together discussing these 7 subtle shifts: the increased physical fatigue, the changes in complex social interaction, the undeniable reduction in appetite, and the slowing metabolism. I must reiterate what these signs do not mean. They do not mean failure. They do not give us a precise calendar date. What these signs do mean is that the body is preparing for a transition, and we, as caregivers and medical professionals, must adjust our focus immediately. Our objective shifts from aggressive cure to aggressive comfort. This is the definition of integral health in the final chapter of life. The greatest challenge for both the patient and the caregiver is often managing the emotional landscape, not just the physical symptoms. For the elderly patient nearing the end of life, the primary need is not more medical tests, but guaranteed dignity and unwavering presence. Dignity, in this context, means freedom from preventable pain. It means ensuring that breathing is easy and that any discomfort is managed rapidly and effectively by a dedicated palliative care team. Do not allow the fear of medication addiction or oversedation prevent you from providing maximum comfort in this stage. Pain management is a moral imperative. And presence, this is the most profound form of care you can offer. Do not feel the need to fill the silence or find the perfect, profound sentence. Often, the greatest reassurance comes simply from holding a hand, from reading a favorite poem, or just sitting quietly beside them. Your stable, loving presence grounds them during a time when their world is becoming increasingly internal and abstract. To the children and caregivers watching this, I want to be extremely clear and direct about 2 things that cause immense worry. First, the loss of appetite. It is perhaps the most painful sign for a caregiver to witness, but it is a natural biological shift. The body no longer requires the same fuel. Forcing food or fluids can actually cause more discomfort. Shift your focus from nourishment to comfort. Offer small sips of their favorite drink, maybe a spoonful of ice cream, but release the pressure of calorie counting. We are nourishing the soul, not hitting dietary targets. Second, the increasing need for sleep and the potential withdrawal. This is not rejection. The elderly brain and body are conserving energy for essential functions. Normalize the increased sleep. Honor the quiet moments. If your loved one seems confused or speaks about people who are not present, practice validation. Their internal reality is shifting. Arguing or correcting them fiercely only adds stress. A gentle redirection or simply affirming their feelings is the compassionate medical approach. The final year, the final passage, is a sacred time. It is a time when all the trivial noise of daily life fades away, leaving only the bedrock of love and legacy. Approach this phase not with paralyzing fear, but with profound respect for the life that has been lived and the gentle process that is unfolding. You are providing the final, most crucial gift to someone you cherish, a peaceful, comfortable, and dignified farewell. If this conversation brought you clarity, strength, or comfort, please consider supporting our mission here at Integral Health. Subscribe to the channel so we can continue to share direct, evidence-based guidance for navigating the challenges of aging and caregiving. Share this video with any family or friend who may be struggling with these difficult questions right now. And please, leave a comment below. Tell me what support means most to you right now as you face these transitions. Take care of yourselves. Remember that love is the best medicine, always. We are in this journey together.